Okay, cool. So we are just gonna start with a little intro and then we'll get into the actual talk. I think everyone can see the slides nicely there. So we are doing travel plus a twist of fever today, and it's going to be presented by Dr. Charlotte. And you're going to have to help me with, is it? Sriruttan-Nel. There we go. Okay. So I've got a little bit of a part of your bio here to just let everyone know who we're going to be hearing from. So Charlotte is a senior pathologist in clinical microbiology with an interest in infectious disease pathology, with 13 years of experience in service delivery, teaching, research across public and private healthcare sector routine diagnostic labs. And the rest of there's actually quite a lot to say, but it is on the link. So if you go to the invite, there's the full bit there that you can read up on everything that Charlotte's done, including all of your publications, which was pretty awesome. So yeah, that's that we're going to be hearing a bit more from Charlotte now. We're hosting the Suitcase Club at the Fire Station Rosebank, which is our clinic, a little bit of sort of where we sit and what we look like, and that's part of our team up there as well. And we are seeing lots of travelers, different kinds, for corporate, for leisure, lots of different kinds of travelers, obviously with a focus on infectious diseases as well. So Suitcase Club, this is actually, I stole from Albi's slides from last month, but I thought if anyone's new, you might want to hear this. We are hosting Suitcase Club just because Johannesburg is sort of a springboard for travel, mostly for work into Africa, but for leisure holiday makers as well. We do see a lot of ill-return travelers as well, and there's not really any formal surveillance. So this is kind of an opportunity for us to get together, discuss, travel-related infectious diseases, and we're doing this in collaboration with Geosentinel. Geosentinel is a joint venture between the International Society of Travel Medicine and the CDC. And essentially what it is a global network of travel health centers that report ill-return travelers and basically pick up if there's any kind of outbreak happening. Ideally, the idea is that we pick it up soon and then sort of report on that. The Travel Doctor Johannesburg is run here by Albi and also in collaboration with Lucille Bloomberg. There is another center in Cape Town and one in Nairobi, but that's it for Africa. That's the only ones in Africa. Okay, it's a little bit from the website. If anyone would like to submit a case to Geosentinel, it is done through the email address on the screen. Otherwise, just a phone call through to our practice. We can assist with the forms that need to be filled out and things, and it's just a nice way to contribute to infectious disease, just surveillance. Awesome. Just one quick little thing about our special vaccines that we have in stock at the moment. We are importing the new killed shingles vaccine under Section 21. Unfortunately, Zostavax has been discontinued and is no longer available in South Africa, which is our live vaccine. So it's the only available vaccine for shingles. Because it is Section 21, you have to apply on our website, and the link is there, but it can be found very easily on the web as well. And then the other thing was about malaria prophylaxis for children. Again, not available in South Africa, so we are also importing it under Section 21. The forms can be filled in on our website as well. So if you have a patient that needs to get malaria prophylaxis or shingles vaccine, the information is on our website. Okay, and now with that, I'm going to hand over. Enough from me.
Thanks, Samantha. Hello, everyone. I hope you can hear me. No. Thanks. So I'm Charlotte, and I currently work at the parasitology lab at the NICD. And I'm going to present a case that I saw together in conjunction with Prof. Bloomberg and Prof. Freen. And we've entitled it Travel with a Twist of Fever. So our patient is a 39-year-old female. She's a vet. She works throughout Southern Africa for Conservation International. She travels extensively throughout the continent and globally, but spends a lot of her time out in the field, specifically in Southern Africa. She lives in Knysna in the Western Cape. Even though she's a vet, more recently, she's working more at the wildlife domestic animal interface and with communities across different rural communities across the continent. So she's very healthy, an athlete actually, with no comorbidities. And we first heard of her when her mother, who's actually a doctor, contacted Prof. Bloomberg early this year. So a little bit about her mother. Her mother's a DTMH graduate. Her mother's also an author of an adventure medicine book called A Wilder Life, Journey of an Adventuring Doctor. And pretty impressive. Her mother's has worked in wild places from Kruger National Park to the Australian outback to the Atlantic Ocean islands, both in the Arctic and Antarctic. And she did all of this with two small daughters in tow following the death of her husband. So mother's very experienced in terms of travel medicine. So the presenting complaint was as follows. Patient had a fever, quite a high fever, ranging between 39.5 and 40.5 around on the 11th of January. It was sudden onset, accompanied by joint pain, especially pain in the ankles, and she had no respite despite taking paracetamol or meloxicam. However, within a few days, the fever resolved, and she felt well thereafter. On the 19th, however, I mean, she's an athlete. She has a resting heart rate of about 40 beats per minute. She says she had an elevated heart rate, which was abnormal for her, and she felt very fatigued. But then nothing further until she noticed again she spiked a fever on the 21st of January. So around a fever of 38.5, accompanied by painful eye muscles, joint pain and discomfort, along with abdominal tenderness. And she was examined by her mother at that point and was thought to have hepatomegaly. So she then contacted, obviously, Prof. Bloomberg. And because of the patient's occupation and her extensive travel, we obtained a more detailed history going to back to the preceding 3 months to see where she's been. So between the 10th and 12th of October, she was actually in the Northern Cape in Kamiskroon. She was working on a sheep farm project there. And the only thing of note she noticed was a bite on her left thigh. She thought it looked more like a spider bite. She didn't actually see what bit her. But there was no fever accompanying that, no eschar, no adenopathy, and no rash. A few days later, it looked a little bit infected. She applied some topical antibacterial ointment. It healed with a small scar and didn't bother her any further. She then returned to Cape Town and was well. And then at the end of October, between the 26th and the 28th of October, she attended an international conference at the conference center there. There were many international attendees. Lectures were given inside lecture halls. She stayed at a local Airbnb in the city by herself and was fine, was well during that time. She continued to be well until she traveled to the Hoedspruit area, beginning of November, to the Kruger National Park. And here she traveled, and as you can see at the bottom, it was for a regenerative cattle farming project. And there are lots of other visiting farmers who joined her from Guyana, which is in the northeast of the South American continent. And you can see they did a lot of work in the field. She did not take any malaria chemoprophylaxis. We know that this is an area of moderate malaria transmission within South Africa, but she did not take any prophylaxis at the time. So as you can see, she then returned to Knysna, and mid-November, about 5 days after the Hoedspruit trip ended, she started feeling unwell with fever, sore throat, dry cough, myalgia, reported complete loss of taste and smell, and what she described as brain fog. So her mum obviously, thought this was probably COVID related. She had lots of contacts recently at the conferences and people she traveled with. No formal testing was done. Patient remained unwell for about 10 days. She noted an elevated resting pulse rate. And she was actually unable to participate in the Ironman endurance event in Mossel Bay and a cycle race for which she was very well prepared. So she was, for her, unwell. But she didn't take any meds, and she recovered well after 3 weeks with and felt back to normal after that. So that was in November. Then beginning of December, she traveled again, this time to Zambia, to the lower Zambezi area. Here she was actually working on a communal project with local fishermen along the river. There were other people who were staying at the lodge, and these are her pictures. And the one in the middle is an image of her lodge where she stayed at. She stayed there alone, but it was a very nice lodge. You can see the picture on the right, cemented floors, tiled floors, very nice accommodation. There were other people visiting from the US, Arizona, Washington, DC, and Canada, but she didn't share quarters with them. And she was otherwise fine during this trip. She went back to the Western Cape for a team meeting. And then it was subsequent to this that she started feeling ill in January. So during her time in Zambia, we did ask, she had mosquito bites and possible tick bites. She did not take any malaria chemoprophylaxis. She cannot recall any tsetse bites at this time. She did not swim in the river, but she said she took a few boat rides. She put her hands in the river, but that was about it. So that was in December, and then she became ill as previously described. So at this point, when Prof. Bloomberg was consulted, I think because of her signs and symptoms, her travel history to malaria endemic areas, the fact that she hadn't taken any chemoprophylaxis, I think first and foremost, we wanted to exclude malaria as a cause of her presentation. She had been to Zambia, and we did want to also exclude trypanosomiasis. There's very few cases of trips being reported from the African continent, but as John and I had discussed at the time as well, most of the cases that we have seen at parasitology, or John has seen over the years, has actually been from people returning from Zambia. So we wanted to exclude that, or thought to put that in the differential. Then tick-related infection, rickettsial infection, African tick bite fever, and relapsing fever were on the differential list. Arboviruses, so chikungunya, Sinbis, dengue, we were worried about or wanted to exclude. And then because of her occupation, brucella, Q fever, and also leptospirosis were on the list. In terms of non-infectious differential, we thought about possible autoimmune cause. She's a young female presenting with fever, joint pain, and so, things like rheumatoid arthritis was something that we were thinking as a potential non-infectious cause. And at this point, we were not thinking of anything non-benign. So the thinking at the time was she was feeling well then. So the recommendation was that she go as an outpatient, get a full blood count, including a diff count, as well as a malaria test and a peripheral blood smear and a rickettsia PCR. And she went off and did this as an outpatient at the private lab down in Knysna. And then the thinking was that if these tests came back negative, then we'd do further testing at the NICD for trypanosomiasis, arboviruses, leptospira, and brucella, as we had discussed. So I can share some of the lab results that she had taken on the 22nd of January. So the biochemistry, the liver function tests, other than just a mildly elevated alkaline phosphatase, the rest of her LFTs were within normal limits. In terms of her full blood count, you can see she does have an anemia, a hemoglobin of 10.8 and a decreased hematocrit, but a normal white cell count. Platelets were also normal. And morphology on blood smear was also reported, and they saw some acanthocytes and elliptocytes, and they saw some stimulated or activated lymphocytes, but nothing else was reported at this point on the peripheral blood smear. She also had both thin and thick films done for malaria, and no malaria parasites were detected. In addition, a malaria PCR was also done, and that was negative. She had serology performed for rickettsia. Both the IgM and IgG were negative. Okay. So at this point, this was the 22nd, and in between, she was otherwise well. We just then hadn't heard back from her. But on the 26th of January, she started feeling unwell with fever again. And at this point, I think the mother started becoming quite concerned. And then we had a really good discussion around going back through all the history and getting all of the information and getting the blood results. So on review, this was her 4th episode of fever. She's been having fever every 5 days for about 48 hours at a time. She had arthralgia during the first episode, along with fatigue. She's got anemia, and she's got these multiple risk factors: travel to the lower Zambezi, contact with livestock, and potential tick exposures. So at this point, because she was now pyrexial again, the suggestion was made that she actually have more extensive testing done during this pyrexial episode. She was referred to a physician in Knysna who admitted her, and bloods were taken during the febrile episode and submitted to the NICD. The plan was to exclude trypanosomiasis, to repeat the malaria tests, to look at the peripheral smear again, because relapsing fever is a possibility, also to look for malaria and trips on the peripheral smear. Blood cultures were done, and then to consider any further imaging or hematological investigations as needed. And she was then started on doxycycline empirically. And we said, the malaria tests were negative, but if she deteriorated any further, then to start Coartem. And I think the clinician made the decision to start Coartem as well. So she had doxy and Coartem. So then the NICD, the bloods came to us, and we repeated the malaria test. So we did malaria rapid diagnostic tests. We did both the Plasmodium falciparum specific and the pan-malarial one. They were both negative. We repeated the malaria PCR. That was negative. And then the Brucella leptospira serology, also negative at the NICD, as well as all of the arboviral serology that was done there for chikungunya, West Nile, Sinbis, and dengue. So nothing positive at this point in time. So still a mystery as to what's going on. And then, so remember, we had they had sent us bloods from the lab when during her initial afebrile episode on the 22nd, and we had done a peripheral blood smear at that point, and we hadn't seen anything. So they sent us repeat bloods from her febrile episode, and this is what we saw. So I don't know if anyone wants to offer, describe what we see. So these are images of Giemsa stained blood smears. The one on the left is a thick smear, and the one on the right is a thin smear. And you can see in each of them, almost in the center of each of those images, a very delicate spirochete, measuring about 10 microns in length and about 0.2 microns thick, with these loose coils, hence the twist in the travel with the twist. But they were these spirochetes are too thin to be seen on a wet mount by light microscopy, but they can stain up nicely on the Giemsa. And to be honest, the technologists really had to look at many fields to actually identify these ones that we see here. So then, given the clinical presentation and what we're seeing on the peripheral smear, this patient has relapsing fever due to Borrelia. And all we can say is Borrelia species, because morphologically they all look similar on the smear. So she had relapsing fever. And then just to make a point that we probably didn't see it on the initial one, because you normally see spirochetes when the patient is pyrexial. You normally won't see them if the blood is drawn when the patient is apyrexial. And you need quite a lot to be seen. So for the thin smear, you need about 10 to the 5 parasites per microliter, and for the thick, about 10 to the 4. And you actually need to look at about 200 oil immersion fields before you call it negative. Yeah, so that was the diagnosis for this patient. And we knew it was Borrelia species, but we wanted to know if we could make an identification to species level. And so we submitted it to our sequencing core facility to be sequenced, and it was very difficult. They had difficulty getting a match, but Profi knows someone at Onistopur who does research with Borrelia, and there was also another local research group that was doing some work. So we sent DNA off separately to both of them, and using the 16S gene target, we got two different results. So we got one as Borrelia coriaceae and the other one as Borrelia lone starry-like sequence. And that was the information that they sent to us. And we put together a phylogenetic tree because we were not expecting either of those. And both of them kind of group with the New World Borrelias, which are usually not seen on the African continent. So it was an unexpected result. So if you look at the phylogenetic tree, the Borrelias that group at the top are usually the ones that are implicated in Lyme disease. And the ones that you see at the bottom, Datina included, are usually the ones that are seen, or the old world Borrelia that are seen on the African continent. And then the ones that are here grouping with ours in red are usually the New World group. So we didn't really expect ours to group with the New World group. But more recently, there have been publications, and I'll show you that there have been some new species identified from German travelers returning from Africa, and they were called Candidatus kalaharica, amongst others. And they seem to group, and ours didn't even group with that grouping, which we thought maybe it would group with that. So there's still more work to be done, whether this is something completely novel or whether we need to look at a more discriminatory targets, but we are going to be doing whole genome sequencing on ours. So maybe then just to tell you a little bit about relapsing fever. So relapsing fever is infection caused by spirochetes of the genus Borrelia, and characterized, as the name says, by recurrent episodes of fever, which accompany the spirochetemia. And it's an arthropod-borne infection. There are two major forms, tick-borne and louse-borne relapsing fever. So the tick-borne is zoonosis, zoonotic in many countries. And the Ornithodorus soft tick are the vectors, or have been traditionally thought to be only been transmitted by soft ticks. More recently, the hard-bodied tick has been recognized as a vector for another Borrelia, as mentioned there, seen in Asia. And there's various different Borrelia species that occur in different continents, as I've highlighted in that tree. Louse-borne relapsing fever is anthropootic. It's spread from person to person by the body louse, caused by Borrelia recurrentis. And it's usually developing world or among refugees from developing countries and can result in large epidemics. So ticks harboring tick-borne relapsing fever have been detected worldwide on all continents except Antarctica and Australia. And the Borrelia bacteria causing relapsing fever circulates naturally between ticks and various animal hosts, usually small rodents, and humans become infected when they are accidentally bitten by an infected tick. Now, these soft ticks that are the hosts live in close proximity to the small mammal hosts, like the mice, the rats, the squirrels, and they rarely leave the confines of their hosts' nests or burrows. But humans may be targeted at night when these ticks become active, when they are sleeping close to these tick habitats. So these soft ticks actually are quite rapid feeders. So 15 to 30 minutes, they'll feed and then they'll return to the place from which they came. So the attack is actually really noticed and the tick is actually really seen. And these infected ticks, amazingly, once they're infected, they can remain infectious for the duration of their life. They even pass it on to their offspring. And they may live for more than 10 years. And they can actually transmit, and they can actually survive without feeding for up to 5 years. In fact, in one report, someone had kept one in the lab for up to 7 years. So they're infectious for their life and they can live very long and they don't have to feed very often. Yeah, interesting. So the clinical presentation, as we had seen in this patient, relapsing fever, which is actually the hallmark of, of the spirochetal infection, sudden onset. You usually have an intervening febrile episode, afebrile period, and then recurrent fevers with very high temperatures between 39 to 43 degrees Celsius. Incubation period, an average of 4 to 18 days. You can have up to 12 recurrent febrile episodes if untreated. Each can last between 2 to 7 days, and you can have afebrile periods in between of up to 10 days. So, yeah. She had 4 days, 5 days in between. per episodes. And then this characteristic relapsing fever pattern is because of antigenic variation. So that's the interesting thing about this Borrelia. They can evade your immune response by this outer membrane lipoprotein switching. So they express different versions of this VMP. And so once the host has the time to then mount an antibody response, it has already switched to another protein. And so then you get this repeated relapse of fever. And that's why I think there's no vaccines against them, because it's very hard to formulate a vaccine against these, the antigenic variation. So other signs and symptoms, so generally very non-specific: headache, myalgia, chills, nausea, vomiting, arthralgia. Can be more severe with neurological complications, delirium, meningitis, encephalitis amongst them. There can be cardiopulmonary sequelae, myocarditis, and then respiratory ranging from non-productive cough all the way to ARDS. And for louse-borne relapsing fever, you can get hematological presentation with bleeding disorders. Patients can have splenomegaly, hepatomegaly, myocarditis, and enlarged painful joints are unusual, but they can occur. So generally, labs findings are supportive, but they can be very non-specific. They can range from mild to moderate anemia. Your leukocyte counts are usually normal. You can have leukopenia in a crisis after the first episode of fever. Platelets can fall. ESR may be elevated, but otherwise things are generally non-specific. If you do a CSF examination, if it's indicated, you can get a mononuclear pleocytosis or mildly to moderately elevated protein level. And in patients with myocarditis, if you do an ECG, you see a prolonged QTC interval. And some patients may also have cardiomegaly, pulmonary edema on chest X-ray. So basically, you need to, in terms of diagnostic approach, patient will have to have had a history of exposure or possible history of exposure and relapsing fevers. That's really the hallmark of presentation. And the others are usually very non-specific. And then, like we said, it's really important the timing of doing the blood smear during a pyrexial episode is when you'll see the organisms. There's a lot of additional tests that you can do, immunofluorescence. You can look at the concentration, centrifugation, and Buffy-coat examinations. And then phase contrast or dark field microscopy can be very helpful. And that image is actually from a infected mouse. And that's an immunofluorescence stain applied to a thin blood smear. And you can see all of the spirochetes in that. So if the diagnosis is suspected and the smears are negative, PCR can be very helpful. It's more sensitive generally. And then if CNS involvement is suspected, an LPN microscopy or PCR of the CSF is indicated. So we talked about a differential diagnosis, but there are many other infections that can mimic relapsing fever. So malaria, definitely one of them. And in fact, often you'll see from the epidemiology that tick-borne relapsing fever often overlaps with areas where malaria is endemic. So in a lot of these countries, they missed on the smear, they diagnosed as malaria, and they come back and they haven't responded. So then they're called treatment-resistant malaria. And so that's probably why relapsing fever is missed or underreported to a great extent. You have to think about leptospirosis, typhoid fever, tularemia, the other rickettsiosis, dengue, and rat bite fever due to spirillum minus, which is seen in Asia. Because there, if you do a smear, you will then see also a bacteria that looks like a spirochete. So there's the other things to keep in mind when you're thinking about a differential diagnosis. And then the ticks that are said that are responsible for transmitting a relapsing fever are not known to transmit other infections to humans. So yeah, you usually wouldn't see something else with it. So treatment. So some of these can be self-limiting. But if a patient is confirmed or has a suspected diagnosis of relapsing fever, antimicrobial therapy is required. Mortality rates for untreated tick bite relapsing fever range between 4 to 10%, higher for last-born relapsing fever, 10 to 70%. But with prompt antibiotic treatment, the mortality rates are substantially reduced, less than 2% in tick-borne and less than 5% in louse-borne. Patients with severe symptoms need intravenous therapy with a beta-lactam. Or oral therapy for those that are not as severe, doxycycline or a macrolide for 10 days. For those with CNS disease and those with who are pregnant, you need to extend treatment to 14 days. And I think the important thing is to be aware after the first antibiotic dose, whether it's tetracycline or a macrolide, the patient needs to be monitored for the Jarisch-Herxheimer reaction, which is a hypersensitivity reaction. And it can occur in up to 60% of people being treated for louse-borne relapsing fever and up to about 20% for tick-borne relapsing fever. And it can be quite severe. So patients can present with rigors, myalgia, further rise in body temperature, increased respiratory rate, and hypotension, which can last for up to 24 hours. There may also be cardiac dysfunction, elevation of TRPT levels, and so they can be quite severe, and the severity is dependent on the number of spirochetes in the blood. So it's very important that these patients be monitored following antibiotic dose, first antibiotic dose for that. So relapsing fever in pregnancy also causes more severe and prolonged illness. Transplacental transmission of infection may occur, and relapsing fever can actually lead to premature labor, abortion, and stillbirth in pregnant women. So in terms of prevention, reduction of exposure to the responsible louse and ticks. In rural areas, they usually are given advice to construct houses with sealed floors, so to eliminate any cracks where these ticks can then live, crawl out at night, bite, and then go back. Advice to sleep on beds, so off the floor and keep away from the walls. Like I mentioned, there's no vaccines currently available, and you can consider post-exposure prophylaxis for tick-borne relapsing fever. And the people that you would consider this in are people who had high risk of infection following a suspected soft tick exposure in an endemic area. So you'd administer within 4 days of the suspected exposure. You would give doxycycline single 100 milligram dose, or a short course, 200 milligrams on day 1, followed by 100 milligrams daily for 4 days. And this longer duration is in situations where there's a greater likelihood of a more severe or more prolonged disease. So people who are splenectomized or have other immunodeficiencies to prevent infection. So what about our patient then? Because we've confirmed she's got relapsing fever. We know it's a Borrelia species. From our sequencing, it seems to indicate it's a New World Borrelia species, but she hadn't reported any recent travel to the US. But we went back and asked her specifically. She hasn't traveled any recently to the US. She did not work with any animals imported from the US. She had shared some time at the travel lodge in Zambia with people who were from the US, and many of them were wildlife conservationists, but she didn't actually sleep in the same quarters with them. So now she's currently well, and she's traveling extensively again for work. She's currently in Ghana doing some project there as well, because we had invited her to come along and tell her story, but she's working and she's well. So I don't know how much of time we have, but just in terms of the epidemiology in South Africa, we know from like as far back as, reports from 1912 onwards, that there have been sporadic cases of relapsing fever in South Africa, mainly in the old Zululand, Transvaal, Cape, and Gauteng, both local and imported cases, especially laborers coming in from northern areas north of South Africa to work in the mines. There was one actual article that described an outbreak in 1936 in mine workers in the Northwestern Cape, where they described 1,800 cases and 160 deaths, so a case fatality rate of 9%, quite high. and they attributed it to Borrelia dutini, which is spread by Ornithodorus mubata, the soft tick seen in that area. So that was back in 1936. But since then, there haven't been many reports. There was this chapter from a book, and it is very interesting and also talked about how ticks could be transported by hosts over long distances. Also makes mention how birds can transmit these infected ticks, and gave a nice story there of a ship's laborer that actually had brought a tick over from can't even read there now, but some other part of the world, and it was really interesting because it gives his details about how the author was called to see the ship's laborer who had been loading cargo on a boat somewhere along the North American coast, and then when he docked in Cape Town, they found that he had he had some lesions and he had ticks. So it's a really interesting read. But I think it kind of maybe speaks to, where did our patient get this infection? Was it brought over by birds? Where there's been reports about migratory bats carrying ticks. But actually, if you look into the more recent literature, and we've actually had a presentation and an expert on relapsing fever, this concept of old world, new world is quite outdated. And so more and more that people are looking on the continent, they're finding cases of Borrelia that group more with what was originally called the New World. So you got this mix of New World and Old World Borrelia-like organisms on the continent, both from like animals like ticks infecting warthogs, clinical cases. And I think more recently, this Candidatus Borrelia kalaharica detected from a febrile traveler returning to Germany after vacationing both here in South Africa and I think Botswana. So the expert seems to think that our Borrelia probably is going to end up being a Candidatus Borrelia kalaharica, and that it's being seen from multiple other countries on the continent. It is spread by an Ornithodorus savigny tick, which is very similar to our Mubata, but except that tick has eyes and Mubata doesn't. But it's very hard to tell them apart morphologically because the eyes are between the legs. So to you and me, they'll look the same. But yeah, I think just to say that there's lots of knowledge gaps in terms of tick bite, relapsing fever on the continent. We know that there are clinical cases reported from all the areas that you see red, but there's still a lot more that needs to be discovered in this space. So it was a really interesting case, and I'd like to thank the patient, her mother, Profs Bloomberg and Prof Freen, and then the pathcare pathologists who did all the initial testing, Dr. Ogilvie and Neisner, and then Dr. Ben Manson Nicola, who helped us with the some of the sequencing work, and the NICD teams. Thanks very much.
Oh, great.
It's very interesting. Yeah.
Before, I just wanted to say for the audience, then you're welcome to raise your hand and ask a question, and you can just unmute yourself. But are there any questions around the table?
Any cross reaction with other spirochetes serologically?
So I believe that there's no serological test available as far as I know because of those issues, that there is cross reaction with others. But John may know more. We certainly don't offer any. Yeah. And I think they do cross react. Yes. Yeah. So it's not the mainstay of diagnosis for sure.
Those ticks aren't in urban areas.
So they're mainly around cattle and in the more rural areas, and mainly like huts and dwellings where there are cement floors with cracks in them. So apparently in that one, there was a outbreak on a citrus farm where they also tried to they broke down all the dwellings and tried to build new dwellings, but they also paid the farm workers, I think 20 pence for a certain number of ticks, and they collected 500,000 ticks during that little citrus farm. So, and the expert that we presented, Dr. Prof. Sally Cutler, she showed a video from Nigeria, a cattle market, and the floor was moving because it was just full of ticks. So very large numbers of these ticks in those areas around livestock.
It's not a human problem, but not directly, but African swine fever, which is a major concern of pig farmers, is a virus, but it's transmitted by soft ticks as well.
Yeah.
So where do you think this patient picked this up? In Cunningham?
Yeah.
Basner, Hotel?
Yeah.
Which brand?
What's
Yeah, no, so we think because of the incubation period, we think lower Zambezi, we think during her lower Zambezi stay. And because that Kalaharica candidatus has been described from new world species have been described from Zambia, both in warthogs, the ticks, and some clinical cases. We think that's probably where she's got it. She had her exposure.
That's when she had the bite. So
No,
it
she had the bite was a red herring. She had the bite when she was in Kamiskroon. So there were lots of things to, and she probably had COVID during that incident where she had the brain fog yeah.
So that wasn't the time between two.
Yeah, that was too long a ways away. But I mean, it just goes to show that people that travel often and have all of these occupational exposures, the history is really important. But sometimes you need to weed out a lot of the information. Yeah. And incubation periods are really important to help guide you as to possibly when the exposure was. She is taking malaria prophylaxis for Ghana, she says. Yeah.
Was it us?
She's taking Doxy.
Yeah.
If you have a bite, you come back. First prophylaxis.
Yeah.
Yeah, we started toxic.
Yeah.
Yes. And our skin as well.
Just have to use sunblock, right?
Yes. So we don't seem to have any questions. I don't know if anyone would like to ask any questions from the chat. I'm just asking again. But I think in that case, I'm just going to go on to our last slide.
That was just in case anyone asked. The morphology between Treponema, Leptospira, and Borrelia. So you can see Leptospira very tightly coiled and usually has and hooked. Treponema is long, but it doesn't have as high amplitude spirals as Borrelia. Yeah. So you can tell those apart, but you can't say what Borrelia species. If you're seeing Borrelia, you can't say if it's Dattani or recurrentus, or you need further testing, PCR.
I'm going to close our online side. We can continue chatting around the table. Just a thank you to Aspen for providing the little snackies for us and some drinks. And that's it. We will see everyone next month. Great.